You're listening to Development Works, produced by Doctors for Doctors and Nurses for Nurses. All right, let's get into it. Hello, friends. I'm Andrew Wilson.
And I'm Michael Carlson. This is Development Works, supported by Doctors for Doctors and Nurses for Nurses. And we are joining you live from our annual fundraiser at Grossman's Tavern in downtown Toronto. That is a real audience in the background, ladies and gentlemen.
I couldn't fake that no matter how hard I tried. No. And on today's upcast, when doing international development, you need to know how to build successful healthcare systems.
We hear from Dr. John that an MD with experience in Brazil's current healthcare model.
So Dr. John is a new family physician with a focus on global health, equity, and marginalized patients. He recently completed a fellowship in global health and vulnerable populations through the University of Toronto's Department of Family and Community Medicine. The fellowship included several months in Brazil, where he learned about the country's primary care system. So John's training also included time in Moose Factory, Atawapiskat First Nation, thank you, and Toronto's inner city. So his interests include healthcare capacity building in low-income countries, humanitarian medical assistance, Indigenous patients, refugees, and the social determinants of health. Dr. John went into medicine after a 13-year career as an editor. Today on the Upcast, Dr. John lets us know what works in international development.
But first, this Upcast is powered by Doctors for Doctors and Nurses for Nurses. We're a Canadian charity that sponsors the medical education of high-potential youth in rural Nicaragua. If you want to ensure everyone has access to quality healthcare, first visit doctorsfordoctors.ca.
So one message is, if you can find your allies in government or in corporations, there are some people of conscience there. And you need to keep your eyes open for opportunities that might present themselves and act, because the right actions at a high level can have enormous impact on the health of millions of people. We were just talking about that earlier. It's change on such a larger scale than what me as an individual physician can do in clinic, or an individual nurse or a physiotherapist can do. So if you can keep your eyes on policy, if you can hold your nose and get your hands dirty within the system, you can often do an enormous amount of good. I want to talk to you about the exceptional case of Rio de Janeiro and its investment in family health teams. So Rio de Janeiro, you might remember, back in 2016, hosted the Summer Olympics. In preparation for this, the mayor wanted to make primary health care in Rio a priority. So he essentially delegated the task of improving the healthcare system to his team headed by the Municipal Health Secretariat. And I had the opportunity to talk with a couple of these people, one of the former health secretaries and then one of the key people that were involved in the implementation of this. And it was quite interesting. These were exceptionally brilliant people. And luckily they were talking kind of off the cuff, so I was able to get a little bit of a flavor for what happened. So essentially the mayor had traveled to previous Olympic cities around the world and learned that primary care and family medicine in particular were foundational components of these systems. And so the mayor essentially, wrote his health secretariat a blank check and said, make me a system like these systems. And so they did. The entire health budget in Rio de Janeiro doubled from 2009 to 2016, and the proportion of that budget that was dedicated to primary care increased tenfold. So in Rio, with a population of about 6.5 million people, they went from 3.5% coverage by the family health strategy in 2009 to almost 70% in 2016. And they now have 1,300 family health teams, these multidisciplinary family health teams. And as I mentioned, I got to talk with two of these key people that were involved in this expansion. And essentially, they were a couple of brilliant cowboys. And I say that with utmost respect. And I'll give you a little bit of a sense of this, okay? So at the beginning, they went to the universities in the area that had family medicine residency programs and essentially said, look, we need to expand family medicine in this city. We need to expand the family health teams. So we need you guys to increase the number of residency spots for family medicine. And the universities kind of hawed and hummed and said, maybe we can expand by a little bit. And these guys said, no, you don't understand. We'll pay for it. We have money. We'll give you the money. We just need you to expand it. We need tons of spots. We need 90 spots. And the university said, well, I don't think we can really do that. Maybe we can, expand. I can't remember what the numbers were, but they were quite limited. And so these guys essentially said, well, to hell with this. We're going to start our own residency program. We're going to start it in the municipality. It's not going to be connected with the university. We're going to build our own. They had the money. So essentially they hired amazing people and started their own residency program. It started in 2012, and when I was there, they had, how many residents was it? 135 first-year residents, 120 second-year residents, and it's now thriving, and it's quite a well-oiled machine. Out of the municipality. I'd never heard of that before. It was amazing. So what this case showed me in terms of just my own personal learning lessons was that sometimes you get really good people in high places.
So Mike here, you'll notice that the sound changed, and that's because we're back in our studio recording the rest of this podcast. So you listeners can hear all the details of everything that's being said. And when I say our studio, I of course mean our studio apartment, because that's how we roll.
Yeah, I love this story. When you have a couple of people who are just fed up with a broken system, so they actually stop playing by the system's rules and build their own residency program, I think big thinkers in high places are hard to come by. And to think that so much of Brazil's current healthcare system came from that is actually pretty crazy, Mike.
Yeah, when I worked in government, I saw this kind of stuff all the time. So people, the general public, thinks that public programs are just formulaic. So you just pump in more money, and then there's more success in the program, when it's actually not true at all. It has all to do with the people, the leadership in government, and the brilliance of those people just changes everything. At the highest level, these decisions that these people are making can actually influence thousands of people, if not millions, to have a good or a bad day, depending on the policy.
Yeah, that's interesting. And in this next clip, Dr. John talks about triage, about cutting costs, and about how nurses are stepping in to take on a higher level of involvement in patient care.
Nurses, they have a larger scope of practice in Brazil than here in Canada. For instance, in Brazil, nurses can prescribe STI treatment, sexually transmitted infection treatment, TB medications, contraceptives, I guess permethrin for scabies. They can refill hypertension and diabetic medications, so long as the first prescription was written by a physician, drugs for Hansen's disease, leprosy, a number of things like that. They can order exams, for instance, the routine exams for meaning investigations like ultrasound and blood work for pregnancy, routine investigations for high blood pressure and diabetes, a sputum test for tuberculosis, mammogram. So nurses can essentially do more, and why not in Brazil? They will also alternate care, another way of, again, saving money and involving interprofessional care is alternating care with physicians for prenatal assessments. Just say a pregnant woman should be seen once a month. 1 month she'll see a nurse. Next month she'll see a physician, and they alternate that way. They also do that for diabetes and hypertension care.
Yeah, Andrew, why can't nurses actually do more? I don't understand. There have been all sorts of techniques and skills, of course, that I've seen that nurses are way better than doctors at. So what's even with that?
Well, so there's a number of treatments in Canada that are regulated for each profession. And regulated just means you have the rights. You're able to do that thing. Like prescribing drugs, for example, is a regulated act. So usually, as any medical professional, you learn all of them in school just in case the rules change. But then you can only practice a certain number of procedures once you graduate. So, for example, Mike, did you know that as a chiropractor, I took a whole series of courses on drugs and pharmacology and how the medicines interact with people. So just as much as medical doctors do, actually.
Interesting, but you can't prescribe drugs, so how does that work?
Yeah, but that might actually change. And if it does, my school needs to have prepared me for that legislation change in the future. So in the same way, nurses get a lot of education on things they can't legally do here in Canada yet. Imagine if we used their skill set to its broadest capacity or trained more of them in nurse practitioner roles. I think it would be really good for our healthcare system.
That sounds amazing. And it's super cool to see this example in Brazil, that they were able to give nurses more authority, and then it actually cut costs and improved care. I don't know. To me, this seems like a no-brainer. It just seems simple and effective.
Yeah, and I really don't know why it isn't done more. I think we're slowly getting there.
Yeah. Well, speaking of ways to use our resources better, Dr. John in this next clip discusses where he thinks we should be actually spending our money.
Yeah, and you might think that it's risky to start your own project in an area of extreme poverty, and that it may be even too risky to get it started there in the first place. But the evidence in Brazil might suggest otherwise.
There was a family medicine resident who said that resources should go where resources are needed. And if you take that simple idea seriously and pursue it, it's really a radical idea. Now, I'd just like to reflect a little bit on instructive elements of the Brazilian healthcare system that I think are important to mention in terms of what works in development. First of all, I just want to kind of come up with a blanket statement about the social determinants of health. I assume that you're all kind of familiar with that term, social determinants of health, yes? Okay. So almost all discussions of health should start with a discussion of the social determinants. And it really kind of permeates, I hope you can find the threads within my talk of the social determinants. And Brazil is a country with profound disparities in its population, such that the solutions to health will involve looking at the structural and social and economic factors that maintain people in ill health, prevent access to treatment, and nurture discrimination. One obvious strategy in that context is simply focusing your energy on the poorest, most marginalized, and most underserviced areas. And that's actually what they did. In Rio de Janeiro, and I think in the country as a whole, the first family health team, for instance, in Rio was in a poor area. They didn't have to do that. They might have felt impelled to do that because of the Olympics coming, etc. But I can imagine that there were some people who were saying, let's start off the first health unit in an area where we can be sure that things will run smoothly and easily and it'll be a good test case. But they didn't. They established it in a very poor area. And they essentially proved that they could make a difference in that area. They gained support from the locals. It was supported by the local community. And then they expanded with that support. So one insight for me is that in your work, not to forget who needs you the most, structuring your work and your choices and your career to focus on the most underserved, the most marginalized.
Man, does Dr. John drop a lot of truth bombs in that clip or what?
Yeah, when I think back to our program, we didn't start in the highest risk area. We started in kind of the middle ground, I think, right, Mike?
Yeah.
In Nicaragua, and we were expanding slowly to the higher risk areas now as we go.
Yeah, but can you blame 20-year-old Andrew Wilson as much as I want to blame you and your younger self? I can't, because you just took the opportunities that came up to help in the places that were available. There was no larger strategy. We're only starting to think about that now. So we're just learning how we can do it better. And I think that's what international development and even this whole podcast thing that we're doing is all about.
Yeah, and just to remember, I guess context is always the most important thing. What worked in Brazil might not work in Nicaragua, and ultimately has to be assessed at the time and place of development by the people involved. I think because we weren't involved with the government in Nicaragua at the time, I could have never started in a high-risk area and seen any kind of result.
Well, yeah, let's listen to this next example Dr. John gives for some specific context of when this kind of thing might work.
One amazing program, maybe this will be the last program that I mention, is this home care program called Melhor em Casa, which means better at home. So it's an interprofessional, you'll notice a theme with me, an interprofessional, interdisciplinary home care team for patients that need to be seen about one time a week at least. It started in 2013, and these are for patients, for instance, that have strokes or COPD, cerebral palsy, that essentially need more interprofessional care that can be given just through a basic family medicine clinic and need more attention. So each team in one home care team that I had the privilege of observing had a doctor, a nurse, 2 technical nurses, which are again like RPNs, physiotherapist, and a social worker. And they also had access to a team that had speech-language pathology, nutritionists, pharmacists, occupational therapy. And essentially, the federal government gives money to the hospital to have this home care team, and the hospital gives money to the home care team with certain conditions. And the conditions are that you're able to help us, the hospital, discharge 25 patients a month. So it's a way of saving money, saving beds in the hospital, and delivering care at home. And they actually found that some aspects of care are just better in the home. Like, first of all, I imagine the patient finds it so much better. But they even found things like IV there's less complications with IV venipuncture in the home than there is in the hospital. They can also get imaging fast because they're connected to the hospital, so they can get the patient imaging quicker through the hospital. So a CT scan they can get in 3 days, or an MRI in 15 days in this one hospital. Amazing, like super fast compared to outpatient. So I guess I'll just quickly summarize the Brazil experience, is that, I love this Brazilian emphasis of going out to care for people in their context. So here in Canada, for the most part, just reflecting as a family physician, we family doctors wait in our clinics for people to come to us. There are exceptions, but, for the most part, we have a lot to learn from Brazil's proactiveness. Just one other thing, in Brazil, they have a group called Consultoria na Rua, which literally means doctor's office on the street. And it's the care team for homeless patients, where they actually go out and they try to find homeless patients, go to where they are, and amazing, beautiful, also interprofessional, multidisciplinary teams that do amazing work.
Home teams for the win. So this actually circles back to helping the people most in need. Our healthcare system often misses people who need the most because they're stuck at home, they're poor, or they're without a home, or they're just neglected by society at large.
And in Brazil, there are even teams that go out and find the homeless to work with them. That just sounds amazing. And I really love the phrase there that Dr. John had said, caring for people in their own context. Super cool. Not a thing that I had thought of before. And it sounds like if it's done in the right way, it actually saves money and can improve treatment.
Yeah, I really, really love that example and that story. That was really powerful. Dr. John, or as he preferred, John, was, in my opinion, an exceptional speaker. So, Mike, you know how much I love all of our speakers. I think they're all great. But what I really liked about Dr. John was his background and engaging with the policies in Brazil while he was helping people there during his residency. And even more importantly, he sat with everyone at the end of the night and just genuinely wanted to get to know everyone in the room. He spent an extra hour after his talk getting to know everyone there, and honestly, he's the only speaker we've ever had that's done that. He was so kind and engaged with the audience, and that is what I will always remember from him. So from all of us here at Doctors for Doctors and Nurses for Nurses, thank you very much, John.
And now, updates for the month.
So, Mike, in Doctors for Doctors and Nurses for Nurses this month, we have written out our 5-year programs plan, which is really exciting. We've been meaning to do that for a really long time. So in 5 years, DFD and NFN plans to have an executive director in Nicaragua, a number of volunteer healthcare professionals in Nicaragua, 6 students and graduates, that's medical students and graduates in Nicaragua, and a DFD and NFN alumni network of those students. So we are trying to connect them after they graduate so they can continue to give back to their communities. Now, this is an important plan to have because it will also act as a guide for our research team at the University of Toronto to write grants for our local Nicaraguan heroes giving back to their communities, which is a really big deal. So I'm happy we finally got that down, Mike.
Me too. On our Canadian side this month, the biggest news is that we're throwing a party right now. And anyone who's listening to this podcast, thank you. Thank you. Thank you very much. Anyone who's listening already missed the party. So sorry about that. Come out and join us next year. That's right. We're throwing our annual fundraiser tonight. There's music, raffles, dancing. That's later on. Overall good times. And all the proceeds go to support our student, Kimberly, in her last year of medical school. And check out our social media for information and pictures of all of the fun that you missed.
And that does it for this month's update on Doctors for Doctors and Nurses for Nurses.
That's everything for this month's episode of Development Works. Thanks for listening.
And this is Andrew and Mike signing off. And remember, if you don't make mistakes, you're not working on hard enough problems.
You know that debate between whether you protest from the outside or whether you work within the system in order to change the system from the inside? I kind of think that that's like the nature-nurture debate. The answer is yes. It's both. You need both.